So we know that there are more of 100 types of HPV. HPV is what is causing the warts and everything that is out there. It infects of our skin, those keratinocytes, and it causes it to have the hyperplasia and hyperkeratosis. Infection, it can be latent, which just means that it's hiding. It can be subclinical, so it's there, but it's just asymptomatic at that time. And then, of course, clinical, it's there and it's working. It's commonly there on some children, some adults, and it's just because of the fact that they're in of a daycare, or they're in of a pool, or they're just interacting, and the contact of back and forth. Okay. Talks about the fact that it can be of the moist surfaces, which I just talked about, of the swimming. Sites of trauma, so hands, it could be up around of the nail, up and under the nail. Why it's talking about biting is kind of odd, because I would not be biting something that's right there. But if you want to chop it off with your teeth, then have at it. With the warts, they could just go away just by themselves after some of the weeks. They can use some of the drops. All of us have seen at Walgreens or Walmart how we'll have some of those drops and the pads. You can be recommended to wrap it up in of the duct tape or some other stuff. So oftentimes warts are more so treated by the patients themselves, unless it's getting into somewhere spot that's not happy. Okay. Of course, it's just all in of the epidermis, so it's not going down into the deeper areas. So there's none of the roots. We will have some treatments, right? So first, we're going to start off with of the creams. We can go into of the cryo. We can do, some curette. We can do all of the things, but we will talk about the ones that you, as a family practice PA or a Modern PA, what you would probably do first. Dun dun dun. Yeah, you can have some scarring afterwards, but okay. So that's how they look. The one that is down at the bottom is one of a common one, or of a filiform. I'm sorry. That is what they look like. We're going to see them in a bit. So it's a papule, 1 to 5 millimeters in size. I talked about of the one that is at the bottom. It's because it has cylindrical projections that will come out and look like art, as it's got a mosaic pattern. So it looks beautiful. What you will see with these things is how they will have some of the black dots, and we're going to be seeing that in a lot of the pictures that we're going to go through. Black dots. So common. Here we go. It's the dome shaped. It's gray up to brown. It's got the papules and black dots that are there. Hands are the most common site. Okay. Treatment here, LN2. So cryo it. Okay. That would be one of the first steps if it is a common wart. Freeze it. If that isn't working, then we can get into the acid of Aldara and then the canthartarate. But freeze it first. And this is what that looks like. So of a cryo gun, It's just freezing it. Um, Once it is drying up, or it could be a day after, you're going to see all of the pain that is there. Okay, so if it's on the hands, if it's on the legs or arms or anything, freeze it first. And a little bit, we're going to talk about the face. Yeah, let's not freeze the face, okay? Because we don't want the face to look like this and feel like this, okay? So, common freeze. Right there we can see some of the black dots. It's cylindrical, right? So it's even and it's of a circle. So you can see some of the black dots. More on of the hand, because it's spread out in there, then we could use some of the ointments or some of the creams to go over all of that stuff. But if it's common, we're going to freeze it first. Filiform. So this has got some of the flesh colored projection. So it almost looks like they're chomping out at you or something. Most commonly on the face, so that's why I said we're not going to be freezing this. We are going to do the curettage. If that's not working, then of course we can get into the cryo and those things. But we're going to chop it off first. And that's what they look like. So it's almost like some hair, something that looks like this is just coming out at you. Face, face, face. There it is again. It's like an octopus, I guess you could say. On the eye, yeah, definitely not going to freeze this. Flat warts. It's of a flat topped of a papule. Oftentimes it's grouped. It can be pink, light brown, yellow. That also is determined by your race, your skin color, right? So it can be like that. Usually it's on of your forehead, around the mouth, back of the hands, shaved areas. Cryo is on there. Aldara is on there. I have always started, and you probably will, of tretinoin. Tretinoin, because if it's on their forehead, if it's on their face, if it's on their lips, we would want to just use that of the cream. So there they are again. Plantar. These are on the bottom of your feet, and they damn hurt. Why do they hurt? Because they're all usually on the heel area, of the toe area, and you have to walk. So you got to step on them, and that hurts. It could be associated with the callus, or some other things, just because of the pressure and the friction. Because of the fact that it could look like it is of a corn, it's different because the corns have all of the skin lines, whereas of the wart, it doesn't have that. It just looks like that same flat wart. Treatment, we don't have to do it if it's not hurting, of course, but it could resolve on itself, like all of our warts do. What we could do, if we would need to do that, is to do debride. So to warm it up with some warm water, to pare it down, and then to use some of the treatments on it. We know that we have all the salicylic acid that is out there. I talked about if we were to go to Walmart and we're going to get some of the drops and of the pads, that over the counter is only of the 26%, whereas if we're going to prescribe it, then it would be up to 40%. Cryo, yeah, let's not do that because of the fact that you're going to see all of the blistering like we saw on the previous slide, and you got to walk on that, and that's not going to be bueno, okay? So let's not do that. So yeah, salicylic acid. We could also do some of the more things that are, you know, attacking it. This right here, if we are trying to heal it up and it's still hurting and it's not getting better, yeah, referral to podiatry and let them do all of this stuff that's up here, okay? Again, there are of the pictures of it. You can see on another slide that I'm about to come out. But here, you can see those the skin lines, and once it gets to the wart, it stops because it's up and underneath of the wart. There you go. You can see those lines again. And now this is a comparison of the plantar versus of the callus. So callus, you can see how it still has all of the lines, whereas on the left picture, you see it disappear. All right. Subungual and periungual warts. These are over here some things that are on your nails, right? So they're on the outside. However, it also spreads up and underneath of the nail. And so, like I said, yeah, it's an iceberg that you see, but there's other stuff up and under of the nails. Sometimes individuals will have these because of the fact that they like to chew on their nails, and so if they get the cuticle and then it's just painful and it's acting up, then yeah, again, biting, yeah, it can be some people. It can get really, really hurt just because of the fact that you are doing that. Treatment. Cryocantharidin, salicylic acid, the duct tape, which we talked about earlier. Duct tape it is, okay, just to get it out. And it's only because of the fact that it's all the way around our nails. So it's not super easy to get these done. So yeah. Genital warts, we have, well, I used to teach this when I was doing the physical exam too. That was years ago. You've also seen these things in infectious disease, probably just going through it with the GU, the GYN. We know that there are those HPV types right there. Most important ones, 6, 11, 16, and 18. 52 and 56, yeah, they're in there, but they're not as frequent or difficult as the first 4 are. We all know that this can have the HPV get into dysplasias. It can go into the cancers. Yeah. Wrap it up. So condoms can reduce the transmission of HPV, but it's not going to be 100% because that stuff can, yeah, it can get in, it could tear, it could do some other stuff. So 30 to 50% of sexually active adults are infected. That's what the textbook says. Pale, pink, and numerous. Discrete, narrow to wide. We can see how the surface is smooth, velvety, moist, lacks of the hyperkeratosis of the warts that were found on other places. They can form into a large a cauliflower-like mass if it is in immunocompromised patients. Spread rapidly over moist areas and may be symmetric on opposing surfaces of the labia or rectum. I'm not going to say what's in quotes over there. The genital warts frequently recur after treatment. So once it's there, it's there. Okay, we have to treat those things when the prodrome is starting to become symptomatic, but they can come and go. Talked about of the HPVs, 16 and 18 is of some cancer stuff, especially 16, 6 and 11, rarely associated, but it could happen. Mostly it is 16 and 18. These can also be not only just on the anus of the penis or of the vulva, can also be oral. Treatment considerations. HPV cannot be completely eliminated because of surroundings of clinical infection. HPV infection may persist throughout the patient's lifetime. So it can be, as we talked about, if it's latent, it's there, it's hiding. If it's the subclinical, then it's asymptomatic. Whereas once the patient is coming to see you, then yes, that's because it is symptomatic. Treatments here, you can see over there of providers administrated. Again, like I said, that's probably of a GU or of a GYN, because I've not ever done the things that are on that left side, okay, so skip those. Go over there to the things that you can give to the patient for them to put it on themselves, okay, so let's start with the Potaflox Philox gel. So let's start off with that. You can see how they have to apply it for the 3 days, then it's off for 4 days, and they're going to be doing that for a month and a half. So that's the first step. Then we have the other two that if the first one isn't working, then we can get it into more as far as the other creams. So first, middle, and last are those ones there. Now let's get to the beautiful pictures. So we can see there how we have that a wound, or it's multiple of the vesicles that are there in the locations. You can have it there, you can have it in multiple sites. Again, it could be of the penis, of the anus, of the vulva. It could be cervical, which you'll see as you're doing the pap smear, or So these are the ones that are no bueno, warts that are because of some of the high risk of the cancers. Now here's some of the differential diagnosis. So here's what's called the pearly of the penile of papules. So they're angiofibromas. This is rare. 10% of individuals could have this. I could say that I have had some patients years ago who would come and say, I've got this and I don't know what it is. So you look at it and you examine it, and they all look exactly the same because it's of all the way around of that area. It is asymptomatic, but it's oftentimes wondered because it kind of looks like some other stuff, but that is normal. Another part of the differential diagnosis is the Boenoid. Okay, these again, they are part of the HSV or of HPV, they could become something that is cancerous or is leading into that. But if that's the only thing that is there as of right then it's the differential diagnosis. Small, brown or pink, flat or slightly irregular, discrete group papules. Looks just like of the flat or of the genital warts. It is sexually transmitted. HPV responds or resolve spontaneously in months to years. How do we treat these ones? Again, everything that is on of the list is there. And part of the differential diagnosis is of the warts, but it's in and of its own. What do they look like? They look like that. So you can see the papule that is there of the brown. It's spread around. There are multiple ones here, as well as here. So that's that. Molluscum contagiosum is oftentimes seen with the kids, but it also can be with adults. The sexual contact, which if you were to see it on of a kid and it's in of the groin or if it's in the genitalias, we would rule out abuse. Adults, the wrestlers, okay, oftentimes because they have to be all over each other to perform their acts. One of the things that will have you to look at it and actually confirm what your differential is it's got a belly button on it. So it's got an umbilicus that is there smack in the middle of it. This picture, you can see it. So like this one's got it right in there, here, there. So that's what they look like. This is a part of the pox virus management. If it is pruritic, then we could use some of the treatments, which we're going to see on the next slide. Very contagious. So like those wrestlers, you can pass them around back and forth. Hence the name. Curette. Curette. What else did we talk about that would be some of the curette? There you go. So we're going to curette here also as the best answer. If that's not working, then we can do the cryo, the retinoid, the other stuff that's down there, but scrape it off. There you can see of the belly button, the umbilicus that is in the middle of it. If you see this, you will be pretty confident that you know what it is. More pictures. Umbilicus. Face. Okay. Now let's get into the last ones of these, and it's all of the herpes stuff. So we have simplex, we also have zoster. They all have the same damn treatments, okay? Because they are the clovers. Every single one of them is a clover, and you'll see it when I get to it in a little bit. We have HSV1, we have HSV2. One can be oral, it can be genital. Two is primarily genital. Oh, asymptomatic viral shedding is primary mode of herpes virus transmission. First episode, so if you just received it and it's symptomatic for the first time, that is the worst one, okay? They're more extensive and severe. Once it is asymptomatic, or if it's latent, then it will come back probably one day, but it's not going to be as severe as it was the first time. Vesicles appear approximately 6 days after contact, may last up to 14 days. So once you get infected or you have the contact, 6 days later you can show it. The shedding lasts longer, so 15 or 16, that is going to go hiding again. Establish the latency in nerve root ganglia. Intercourse, skin trauma, cold or heat, stress, recurrent infection, and menstruation can trigger the reactivation. Okay? It's there and it's going to come back. Flare-ups, I just talked about the fact that it's less severe. If it's back, itching, burning, or pain will be there before you actually see the lesion. Virus can be cultured for approximately 5 days when a patient presents with active genital lesions. Talked about the flare-ups, and the recurrence is not going to be like it's gone and it's going to happen like the next day all over again. So there is some time of the frequency that are there. Grouped vesicles on an erythematous base. I'm not going to say that it'll be on my test, but it will be on pants for sure. That term right there, you'll never forget it. Grouped vesicles on an erythematous base. Superficial lesion, slight central of the umbilical. In 2 to 3 days, then erode and ulcerate. Crust form, then heals without scarring in 2 weeks. Lesions are there, but prior to that, you do have some of the burning and of the pain letting you know that it's on its way. Discharge, dysuria, lymphadenopathy are also common, as well as fever, myalgia, and lethargy. Here are some of the types of this right here. So we have the gladiatorium, athletes in contact sports, gladiator, okay? Gladiator. So that one is easy to pretty much see it. What is herpes? Gladiatorium. I don't know. Athletes. Ocular herpes. That will be if you are doing some of the staining of the eye. I mean, you can see the dendrite that is up and in there. Yeah, if I were to see that, we're going to send you to ophthalmologist because of the whitlow. So it's the distal phalanx of the hand. It can be seen with all of you wonderful healthcare professionals, so put your damn gloves on. The thumb-sucking children is there also. So whitlow. Here are some of the pictures that are called grouped vesicles on an erythematous base. Okay. Must look at these lesions. But what we can also do is the PCR that is the gold standard We can swab it, we can put it into the tube, send it to the lab, and you will know that day what the virus is. We will have to do that though if the patient is in there and it's because of the fact that they are symptomatic at that time, then swab it because it does have to be active. Other than the PCR, which is the gold standard, we can also do the zinc prep, specifically looking for the giant cells. And then, of course, serology will be between 1 and 2. That's what it looks like. Management. I said it earlier. Every treatment is of a clovir, okay? So if I were going to test you, I can't put all 4 of those on there because I'm telling you the answer is a clover. A clover. Of course, we know that all of our management of the treatment is, it's not going to cure it. It's just going to subside it. So it's going to ask it to go hiding. Down there, it's some of the of a clover for the lips. Abreva is again, it's at Walgreens, Walmart, everywhere. Episodic, we can have them just do some of the self-administered, but if it's chronic, then we can actually prescribe it so it's just a daily of a treatment. If it's not getting better, is it just because of the fact that they're not using stuff, or if they're doing other stuff like we talked about of intercourse, of the menstruation, that kind of stuff? Do we have to get that stuff fixed? So if it's episodic, you can have the clovers that are up top 3 times a day, twice a day, daily, those things if it is episodic. If it is suppressive, it's the exact same medications but with different the doses. So here I'm going to prescribe them this and they're going to do this daily just because of the fact that it just keeps coming and coming and coming over and over. This would be of a patient to say, I'm tired of this with all of the creams and this and that. Let me just have a medication that I can take every day and I don't have to deal with this because I'm tired of it already. All right, lip. I said lip because here it's lips. It can also be oral, grouped vesicles on an erythematous base. Seen here. Again. That one is very erythematous. All right, last one. Zoster, shingles. It is in of a single of a dermatome, which is where of that of the virus is at, and y'all should know all of the dermatomes because we even started that in your freshman semester, and it was by who? Okay. So talking about that, we've got some of the red swollen of the papules and of the plaques. It's going to be complete all of the dermatome, or it can just be parts of it, but it's going to stay in one the dermatome. Clusters on an erythematous base. Clear and change to cloudy and purulent, then erode, rupture, form crust. All that happens over 2 weeks. What do we think that the treatments are? Clovers. Okay, so same exact thing there. Treat within first 72 hours. Because of the fact that they're having some of the pain, they will either see you in an ER or try to get an acute appointment right away. Because of the fact that it's so painful, we can prescribe them some of the opiates. If they're in there laying on the bed crying, then yes, I'm going to send you out of here. Soaps, I talked about it earlier. If you're having some ophthalmic area, then you would want to send them to ophthalmologist. So the trigeminal nerve, ophthalmic, maxillary, and what's the last one? Yes, good job. There you go. Treatments. Zoster. Clovers. If we have to prevent it, we would recommend that they have some of the vaccines on this there. You can see there that it's often or very recommended for those individuals who are getting over the age of 50. So there are some of those there. We can obviously see that this is ophthalmic, so it's up there. Looks like it does spread a little bit more, but yeah, we're gonna send you somewhere. Again, if you were to do a slit lamp after fluorescent, you can see some of the dendrites there. So it's easy to see. But we can also have it down on the mandible. This is the cranial nerves, the back. You can see how it's staying in that area. It's not moving around. It's staying on that one dermatome. The one that looks more specifically like that as it's getting towards the end is that one right there. So it's just wrapping it up, yada yada. And now y'all can have some lunch. Do we have any questions? All right, get something to eat. Huh? Oh.
Oh, you mean HTTP?
Would y'all like for me to go talk to her? Yeah? All right. Her office is right next to mine, so I will let her know.
No, not you, but the actor. Because it sounds like you're trying to reach out to talk about.
Yeah, they
It's upstairs.
Oh, I was hearing over here.
Oh, I see. Okay, well,
So I'm
I
just
mean,
gonna.
I can go talk to her. She normally always takes the full 2 hours.
How is that? It's the same thing. And then they'll just am I wrong on that? But you know, right. It has nothing to do with the fact that there's still people that get vaccinated. But there's something that separates so that's like I've been following this yeah. It's unfortunate because it truly I feel for how important decision making is. It's not even if you're vaccinated, the most important a lot of those vaccines are on their insurance. I've been watching that.
It's small.
I mean,